Hello, guys and girls. The program you are about to hear will be both fun and educational, but it is not a substitute for medical advice. Although we are doctors, we are not your doctors.
Hello and welcome to Travel Medicine. As always, I'm your friendly neighborhood internal medicine doc, Dr. J.
Hey guys, Dr. Santhosh here, your neighborhood-friendly pediatric infectious disease doc and researcher.
And as we are still in Spooktober, but I wanted to keep it uplifting, I figured we'd cover, something scary, cheery, somewhere in between.
Yeah, like Hocus Pocus.
Something cheery, something scary. Let's talk about, cancer.
Okay, no. What? What are you...
No, but little cancer.
Little cancer?
Little
Tiny cancer.
Hold me closer, tiny cancer.
Listening audience, we've been talking about this pun all week. Like, if you pull up next to me and my windows are rolled down and I'm like scream singing, hold me closer, tiny cancer to Beverly Boulevard.
So let's introduce our special guest expert for the week who's going to join us on a magical, whimsical ride through the world of pediatric cancer. A series of words I bet you did not expect to hear.
Yeah. So allow me to introduce my friend and colleague, Dr. Nicole Bakke. She is a graduate of the Ross University School of Medicine and has gone through University of Nevada for residency and comes to us from the venerable University of California at Irvine and Children's Hospital of Orange County, where she completed her fellowship. She's absolutely tremendous. Pediatric oncologist, Dr. Nicole Bakke. Hi, Nicole.
Hi. Well, thank you for the robust introduction.
Let's wander on over to the Wayback Machine and go over a couple historical ones that you may or may not be familiar with, Dr. Nicole. The oldest description of cancer was discovered. Santhosh, do you want to guess where I'm setting the dial for the Wayback Machine?
Is it your favorite way back of all time, ancient Egypt?
It's
ancient Egypt. It's breast cancer, isn't it?
Yeah.
Absolutely. The Edwin Smith Papyrus.
Yeah, okay.
Describes 8 cases of tumors or ulcers of the breast that were removed by cauterization with a tool referred to as the fire drill.
Oh, that can't be.
With the level of technology available at the time.
Nicole, where do you keep your fire drill?
That's kind of frowned upon. I do use tiny tinkers of poison, but no.
Yeah. There's no fire drill closet in the basement.
No.
Oh. Okay.
However, the writing says about the disease there is no treatment, probably why the fire drill fell out of favor. What's this going to do? Nothing, really. Well, then why are you doing it? Just because it's a fire drill. Wouldn't you use it? But then jumping forward a little bit to around 460 to 370 BC, the age of Hippocrates, we first got cancer named carcinos, the Greek word for crab or crayfish, as well as carcinoma, 2 separate words. He used them to describe, carcinos was to describe ulcer-forming tumors, and carcinoma were non-ulcer forming.
I didn't know they were separate at that time. I always think of oma as like Carson, but just as a solid body. Ulcer-forming cancer such as, Nicole, what's a good example of a cancer that ulcerates?
Some of the breast cancers.
Okay. And then Yeah.
There's too many ulcer-forming cancers that you think about in pediatrics as much. I mean, and I don't think they're talking about colon cancer in those days because they weren't doing colonoscopies that I know of.
They were solid tumors. So in Greek, these words refer to the crab, most likely applied not because of the urban legends that the pain pinches like the claws of a crab, but because the finger-like spreading projections from a cancer to the surrounding area call to mind the shape of a crab's legs.
Is that kind of still how it's described when you see a solid tumor kind of wrapping around?
I mean, it depends on the type of cancer. I think one that comes to mind when you think about that is neuroblastoma, fairly solid tumor that's fairly common in toddlers, and counts for about 15% of pediatric deaths. And if I recall correctly, and I may not be right on this, it's about maybe 5% of all pediatric cancers, but it's obviously a higher number in the very little ones, those toddlers and preschoolers. But when surgeons talk about going in for that, it adheres to everything around it. So it's a very surgically challenging case because of how sticky it is. And some others are not always as challenging to get out. But neuroblastoma is notorious for just matting and adhering to everything around it.
So grabby and sticky. So yeah, so still very apropos of the crab analogy. Josh, we've talked about this before. Everything goes to crab.
Right? Carcinization.
Yeah, exactly.
Ultimately, we all become crab.
Yeah. Nicole, we were talking about this in terms of evolutionary biology. Crabs have evolved several times over the vast, kind of epochs of life. And it looks like everything likes to become a crab, no matter what it starts out as, especially in the ocean. So everything goes to crab.
Yeah, and people get crabby as they get older, so it makes sense.
Oh, zing.
But treatment was based in the times of ancient Greece on the humor theory of your bodily fluids, black and yellow bile, blood, and phlegm. According to the patient's humor, treatment consisted of changes to the diet, bloodletting, and or laxatives. So obviously nothing like oncology today, which treats cancers with changes to the diet, blood depleting medications,
sure,
and or laxatives.
We give a lot of laxatives.
We do. That's true.
We do.
Yeah. The number of times where you and I have had that conversation of, is this diarrhea from an infection or is it from the erelax?
It's always the erelax.
It's always the erelax. Yeah, absolutely.
Oh, just to be stocked up, you got to do something. You can't just let them walk around plugged up.
Yeah, that's true. That's a whole different kind of tumor in there.
Other set of problems.
Yeah. We used to call that one still kind of a tumor, though. Back in Miami, we used to call it a fecaloma.
Oh, yeah.
Yeah. So it looks like, the diarrheal part, it's, getting people to move and using laxatives are because the chemotherapy that you're using, some of them have the tendency to cause more constipation. Is that what's going on?
Yeah, like particularly you think about vincristine, which is used a lot for like our leukemias, is very notorious for being constipating. And then a lot of these kids, depending on what they've got, they may have pain. And so they may be on opiates, which obviously are going to hit the nerves in the bowel and slow down transport and cause constipation. So a lot of times these kids will have reasons for getting constipated from our medicines, but then, usually shockingly, once you start treatment, a lot of times these kids start to feel a lot better, which seems a little bit counterintuitive because you think I'm starting chemotherapy. These kids are going to feel so sick. But a lot of times the cancer starts responding, particularly in your leukemias and your lymphomas, and they feel significantly better, sometimes in days to weeks. Now, obviously, we're not out of the woods and they have a lot more treatment to go, but they feel so much better. They're moving around. Right. Whereas they're not, they may get constipation just because they're sitting in bed, depending on if they're having pain, or let's say you have a bone tumor in your leg, you have an osteosarcoma, like it's really hard to get up and move about. So you get constipation just from sitting there.
Oh gosh. Okay. So multifactorial.
Yeah.
And then we kind of ruin everything because our new children's ward, we've put iPads and TVs in every single room. So they have zero reason to get up and move, these poor kids.
I think my kids are moving about more. They're so
more than the
excited
other.
About like the media room and being on the level where they can go out to the gardens more easily. Floor is just so bright and light that I think they're like walking around more. But a lot of times, patients that are on my service are admitted for longer periods of time. So they may be there for days, sometimes to weeks, sometimes months. And so I think they probably get into a little different routine than a child that's there for a more common reason why a kid would be in the hospital, where maybe they're in for a day or two, maybe a week max. So, and they're frequent flyers. So I think they're just bored.
Used to it.
They're like, they want to wander around. They know everybody. I had one kid who knew all the security guards. I was like, how does he know everyone?
That's so cool. And all the while you are, balancing their humors, lowering the blood and getting the diarrhea going and all the same stuff like the ancient Greeks did. So
the more things change, the more they stay the same.
More the same.
Now we all know. So now we've explained where cancer comes from and carcinos. Tumor, of course, is Latin for swelling. But if we hop one language over back to Greek, the Greek word for swelling is onkos, giving us the name of your specialty. So as doctors go, Dr. Nicole, you are swell.
The doctor of swelling.
I am.
So let's start with one of the very first cancers discovered, or not first discovered, but we'll say the first environmental cancer. And it involves a physician known as Percival Pott, which is about as British a name as you can come up with.
Yeah, so he was a doctor of swelling also, but we talk about Pott's disease, right?
It is that Pott, but this is not that story.
Yeah, and he did have a Pott's puffy tumor, but it's not cancer; it's infectious, where the sinuses puff up.
Picture the world of Mary Poppins.
Oh yeah, all right.
She's floating down from the umbrella with her umbrella onto the chimney tops with Dick Van Dyke, and before everything supercalifragilisticexpialidocious, you see a wide variety of chimney sweeps. A bunch of young boys, chimney, chim chiroo.
Beautiful, soot on their cheeks. They're a little raggedy, and they're carrying their brushes, their bristles. So there was no way to kind of clear out smoke in ye olde times, 1900s. But this is even before that. So you had to get a job. You could be hired to go and clean out the chimney so that you could use your fireplace without all the smoke backing up into your house and, killing you. So.
Well, there's a couple of historical inaccuracies with Mary Poppins. Shocking, I know.
Okay. Those accents were perfect.
Oh, no. The accents were spot on, as was the interaction between humans and animation. Like, that's true to life. But chimney sweeps often wore no clothes, so they were as small as possible to fit into the narrow, twisting Victorian chimneys.
What?
Yeah, they went in and cleaned the chimney like Santa Claus.
No. Okay, stop it right there. Santa Claus doesn't come down the chimney naked. Nicole, Santa Claus doesn't come down the chimney.
Do you know that, Santhosh? Are you staying up to see him?
Oh, God. Okay, so relate this to medicine somehow before I get grossed out.
Oh, and then the other part is all those children in that song would be dead of cancer.
Oh, no.
But there's a happy ending to this story. Stay with me.
Okay.
So Percival Pott, 18th century England, noted that the scrotal cancer very, very commonly afflicted chimney sweeps. Young boys sent up into chimneys to clean away the soot left over from fires. And he started to think that, all this soot that they're exposed to, it's the only consistency I see that might cause that type of cancer. So this is one of the first environmental factors contributing to cancer we know about. So, at the end of the day, it's still due to smoking.
So I'm sure you're going to tell me, but I'm guessing that, when they saw the scrotal cancer, I'm guessing that was metastatic or something, that like it had to come from the lungs or somewhere.
Well, again, remember the chimney sweeps wore no clothes, so they're crawling around. So the cancer would appear on the bottom of the scrotum,
Okay.
and manifested as a painful, ragged sore with hard raised edges that was so common in this field, the chimney sweep trade called it a soot wart.
Nicole, I don't think that this sort of thing is common, like at all in any of your practice, right?
No.
No.
Is it a skin kind of cancer that they're describing?
It's
Or
on
is
the
it more of
outside,
a
right? It's
It doesn't.
yeah.
So yeah, it's an ulceration. I will, if you really want, I'll include a link in the show notes.
Sure. But it's on the skin. It's on the outer surface of the
On the
scrotum.
skin,
Yeah.
okay.
Now, because
Okay.
the sore never appeared in males before puberty, most surgeons considered it a symptom of a sexually transmitted or venereal disease. Think about that
Oh.
for a minute.
Okay. All
This
right.
sore did not appear in males before puberty, so the surgeons at the time said, these kids are sleeping around. Bunch of slutty 8-year-olds.
Wait, no, but it didn't appear before puberty. So like they like teenagers. He was
Took a while for it to
Yes.
right.
Sounds
So
like-
he was alleging that they hit 13 and just was like all these kids would hit 13 and immediately jump into the sack.
pretty
So
much. That's what they're saying, but it probably
yeah.
So as such, because
Yeah.
they thought it was a venereal disease, they treated it with ointments and salves, which did nothing to stop it from spreading from the scrotum to the testicles and then up into the abdomen.
Oh, okay.
And Pott was one of the first surgeons to suggest removing scrotal tissue at the very first indication of a sore, because if it spread to the testes, you couldn't even halt the spread of cancer with castration. So he has an idea of metastasizing.
Okay. The early treatment, early cure.
Now, he noted that he hypothesized that the cause of this scrotal cancer and soot association was the way the soot lodged in the folds of skin and the multiple surface area. And
Okay.
because we as scientists do not let something like this go unstudied.
Yeah. Sure. Did we get like a historical oncologist kind of thing?
Even better, in 2015, researchers have determined, we won't go into the multiple, we'll just say no chimney sweeps are harmed in the making of this study.
Okay.
But as of 2015, researchers determined that soot lodged in the skin of the scrotum would exfoliate away cells at a rapid rate, which then caused cells to replicate more quickly, enabling a higher probability of cancer-causing mutations to occur with frequency.
Oh, wow. So Nicole, rapid kind of induction of rapid cell division. So this is like the kind of the heart and soul of most of the cancers that you treat, right?
Yeah. Most pediatric cancers are not genetically linked. It's, 5 to maybe 10%, depending on where you're looking, will find a reason. Like the family has leaf-Romanes or, the P53 mutation, and they have inherited increased risk of cancer. But for environmental reasons in general, we don't really have a cause. So something is happening to these kids and we just haven't figured it out yet. But it sounds like they figured out what happened with those chimney sweeps, and it seems like a very plausible hypothesis. Furthermore, they probably had less access to bathing, so it probably sat on the skin and continued to irritate it.
Now, all of this was discovered, in the late 1770s by Pott himself, if not to that level of specificity. So by linking soot exposure to chimney sweeps scrotal cancer, he established not only one of the first environmental causes of cancer, but convinced the British Parliament to pass the Chimney Sweepers Act of 1788, which prevented boys under the age of 8 from becoming chimney sweeps and mandated they be given clothing to protect their bare skin from that exposure.
Like government actually like protecting and helping people.
Well, the rate decreased of scrotal cancer in that population. See, so happy ending.
That's so good. Okay, so you are giving us like a spooky but light Spooktober, and I hope that everyone, as we keep listening, keeps getting that vibe, because I'm going to spoil it a little bit, Nicole, but like working with cancer in children is pretty cool because a lot of kids do well.
Yeah, about 80 84%, have a survival rate 5 years. And usually you think if you make it 5 years, you're cured. So this is not the same thing as grandma and grandpa getting sick. Now, granted, there are still some really horrific cancers. There's some bad diagnoses, but taking all players walking into my clinic, most of the time, it's going to have a happy ending.
Yay! That's so awesome. Josh.
It may not be a straight road. It may be pretty winding and torturous, and sometimes, they may have bad side effects and it's not easy, but most of them are going to make it. So it's an exciting area to practice in.
It's my absolute favorite. That's why I love pediatrics too. Absolutely the same thing with infections. Like a kid, an adult, all things being equal, and they get the same infection, our kids are going to do so much better than a grown-up. The thing where you were talking about where you have rapid cell turnover like that, and eventually you start to get, mutagenesis, and then they divide out of control and turn into cancer. This is a lot what we associated with things like human papillomavirus as well, as a for instance, is that the virus is replicating and it kind of forces the cells that the virus lives in to replicate and replicate and replicate. And when that gets out of control, these little checkpoints that are supposed to keep errors from happening fail. And so, it's kind of neat. We talked about that kind of a skin cancer and public health, and it got better. And Nicole, nowadays we've got HPV vaccine, and we can prevent cancers. Same kind of thing.
Vaccine.
Yeah.
It doesn't have a great vaccine rate, but if they get the vaccine.
And one day, Santhosh, on another episode, perhaps as bonus content for our Plus listeners, I will tell you the story of how the HPV vaccine comes from the grand tradition of the jackalope.
The jackalope? The little rabbit with the antlers?
That's the one. Directly, or at least significantly indirectly led to the creation of the HPV vaccine.
Oh, I'm going to have to hear that sometime. Absolutely.
Now, before we go into the next historical fun fact, let's talk a little bit about cancer in general and get into a bit more of the specialties. So just to lay out for a listening audience, there's two main flavors of cancer, solid and liquid. Solid tumors form a mass or multiple masses that grow in organ systems and can occur anywhere in the body, like breast cancer, as mentioned before. Liquid tumors would be the ones in the blood, bone marrow, or lymph, and they can circulate around the body through the bloodstream. I think at its most basic level, that's a reliable description. Would you agree, Dr. Nicole?
Yeah, I think that's fair.
So now let's talk about, as a pediatric oncologist, what are the most common childhood cancers?
Brain tumors are pretty common. And then probably the one that everyone thinks about is acute leukemias, either acute lymphoblastic leukemia or acute myelogenous leukemia. And pediatric acute lymphoblastic leukemia is the most common childhood cancer. And it's really kind of the poster child for what oncologists want to be able to do. In that prior to 1950, the mean survival was 2 months. And now, depending on the subtype, so basically meaning everyone's passing away. Yeah. And now, depending on the subtype and the genetics of the tumor, 85 to 97% survival rate.
Whoa.
For all comers. That's not going to bone marrow transplant. That's just with upfront chemotherapy. So it's remarkable, and it's due to research. It's due to research that was funded by the National Cancer Institute, the National Institute of Health. It's through cooperative groups that pediatric oncologists have formed. And it really is, I've gone to medical conferences with both pediatric and medical oncologists, and it is often brought up of, we wish we could do to X cancer what the pediatric oncologists have done to acute lymphoblastic leukemia. It's just that remarkable.
Yeah, they're envious.
Prior to the 1950s, they couldn't differentiate between the two major subtypes. It was universally fatal. Most of the time, these kids passed away from hemorrhage and severe infections. In the 1950s to 1960s, people started doing research. Dr. Sidney Farber was up at Boston and is a pathologist, and he was looking at the cells trying to figure out what was going on, and he realized if you give folic acid to pernicious anemia patients where they're missing some vitamins, they do better. And leukemia kind of looked like that. So they tried giving folic acid to leukemia patients, and it actually sped things up. So then they made
Whoops.
Yeah.
Science.
Yeah.
So he was like, wait a minute. He tried, hopefully I'm saying this right because it's a medicine that we don't use anymore, amiturin. And it was an analog of modern methotrexate, and it slowed things down. So, research was starting during that time period. There was a Nobel Prize awarded for creation of mercaptopurine, which interferes with DNA metabolism. And prednisone was being used on everything. So they used prednisone with that. But all of these things were being used as like single agents. And so they would all extend life, but these kids were still passing. Then they started doing studies. And they started with really the Roswell Park Cancer Institute in Buffalo, New York, and the Memorial Sloan Kettering, and the NCI, obviously down in DC. And some remissions were achieved, but they defined remission very differently. It was the patient felt better, they started eating, and the petechiae, or the rash from the low platelet counts, went away. And platelets are the cells in our body that help us scab if we're bleeding. So you can it's an oversimplified analogy, but almost like bricks in a wall. So they help make that scab.
So how's remission defined now, if back then it was just return of appetite and disappearance of rash or petechiae?
As time went on and they were able to better delineate exactly what it was, AML, ALL, subtypes, they used the microscope. So basically, depending on the type of leukemia, it's either 25% of the bone marrow or 20% for AML is with blasts or leukemia cells. And when you got that down to less than 5% or non-detectable, preferably you're not finding any blasts, that was considered remission. But since the early 2000s, they've had a technology developed called MRD, or minimum residual disease testing, where they're able to find like 1 in 10,000 cells. And so now we have both a pathological or morphological remission and as well as a molecular remission. So we really rely more on the molecular remission now to know that we've wiped out everything that we are capable of finding.
That's so cool. So as your tools got better and better to find less and less cancer, like to detect the tinier and tinier concentrations, then your definition kind of moved with that. And likewise, your success rate. And now like one kind of followed the other until we're here today. And your expectation for a kid with low risk, pre-B cell ALL is like 100%. Well, that's not fair. It's very close to 100% that they're
if it's a low risk patient, then they, by definition, have to have good prognostic genetics, and it's about 95 to 97% survival rates usually.
Dude, so
it's crazy.
Awesome.
Like it's insane. 0 to that, and. It was the 1960s is really when they were able to define that remission that you were asking about. But then they started doing the phases of therapy that we do for acute lymphoblastic leukemia. It's very like every month to 2 months, it kind of changes until you hit a maintenance phase. And then you do the same thing. And traditionally I think those studies were done in the 1980s, if I recall correctly, they were looking at how long we should do maintenance. And it was determined that for little girls, 2.5 years equaled 3.5 years, but they had less side effects if we did 2.5 years for their survival. So the survival was equal, less side effects. So they got 2.5 years. And little boys had the survival rate was equal to little girls, or big girls, I guess teenagers too, if they got 3.5 years of treatment. And it was lower if they only got 2.5 years total treatment when you added in the maintenance, when they were trying to determine how long we have to do maintenance. And they initially attributed that to the blood testing barrier.
The barrier between the blood and the parenchyma of the testicles.
Yeah, because it's a sanctuary site. So it's somewhere where leukemia thrive.
All right.
Just like the
I never
CNS.
thought of the testicles as a sanctuary. Sorry. Okay. So
just like the CNS, which is why we now in the 1970s, they realized that they were starting to get remissions in the 1960s, but they were relapsing in the CNS. And so they realized even if they had no frank disease in the CNS or the fluids that surround and kind of help cushion the brain and the spinal cord, that we need to treat that anyway. Well, they went a little overkill and they did radiation. And eventually we realized we don't have to do that much if we're just doing it as prevention, but that it made dramatic changes. So that's why these patients have to get lumbar punctures, and we take out some of the fluid and we look at it and make sure we're not finding any cells there that we don't want there, no blast. And we give them medicine throughout their treatment to help prevent any cells that may have crossed into the CNS and try to protect them from having that relapse. Because again, it's a sanctuary site with the blood-brain barrier.
And this is why boys are always so much more trouble, right? Is that you got everything you do, and you can kill cancer in 2 years with a girl, or 2.5 years, and then fine, it's a boy. Damn it, another year. So,
but things have changed, so now it's not that way anymore. So
okay.
Now they've evened that out. And the reasoning being that now we know a lot more about the cancer. So we know more about the genetics. We know more about the MRD, finding that minimum residual disease, finding those cells that are hiding. And so we're better able to risk assess. And so they've, within the Children's Oncology group, have been able to reduce that down to about a 2.5 year total treatment with maintenance for both boys and girls. Some other research groups have also done that as well. Around the world. I think COG was, and a Children's Oncology group is funded by the NIH and NCI.
Take a moment to step back from the cancer itself and look at one of the things that's really led to its rate decrease, which is, of course, chemotherapy and the treatments. And I have a fun little story about something terrifying that ended up helping. Again, this is how most of my stories go.
Is this going to be another one of your famous "this used to kill people, but now it helps people" kind of stories?
Are you going to talk about APL, where we get to use rat poison and zit cream?
Oh, that's one I'm going to have to look into. So we'll stay tuned for that.
Or yeah. Actually, maybe we can hear about both of them today. But let's hear about what's the one you have first, Josh.
Hold that thought, because I want to know more about rat poison and zit cream.
Yeah, we got to hear that one. All right. So first, Josh's weird killer poison that turned into be good thing, and then Dr. Nicole's one.
Let's visit a historical period that we really haven't looked at too closely, which
the Victorian era.
No, I promise. Oh. I promise it's something new. World War I.
Oh, okay. A little bit more modern. Sure.
Yeah.
Okay.
World War I, when in the trenches, you saw the use of chemical bioweapons like mustard gas.
Oh, okay.
Due to its vesicant action, or skin blistering, the gas would cause overwhelming infection in any soldiers exposed to it. And interestingly, leukopenia, or a lack of white blood or infection-fighting cells, was found to characterize the infections. Now, because they're soldiers, a lot of them underwent autopsy, and atrophy of the lymphoid was also noted, which was first reported in 1919, treating a whole bunch of exposed patients in France. So it was known that mustard gas could affect the blood cells.
Gotcha. So you're killing off white cells and the lymphoid organs. So, your lymph nodes. So like your tonsils and those little lumpy things that you can feel that get swollen up when you're sick. So, okay. So this mustard gas was destroying those. Okay.
So mustard gas in and of itself can cause skin irritation. It's dose dependent. It can cause things as minor as skin irritation and conjunctivitis, all the way to severe permanent lung damage when inhaled. It can have chronic sequelae, where people who survive can have nausea, vomiting, loss of hair, increased vulnerability to infection. And a lot of these, and this is important, are the result of this poison acting as what's called an alkylating agent. It will damage the DNA, resulting in a decreased formation of blood cells or platelets.
Gotcha.
Now, it wasn't quite known to that level of detail, but it was known that it could act as an irritant and could cause a lot of damage to some of these organ systems in general. And that was it for World War I. Jumping ahead to World War II, the U.S. Office of Scientific Research and Development, which I believe is a precursor to the CIA,
okay.
but funded Yale University to conduct chemical welfare and weapon research in secrecy. Chemical warfare, not welfare. To conduct chemical...
Okay. All right. So
they funded Yale University to conduct chemical warfare research in secrecy. And this team was led by two pharmacologists, Dr. Alfred Gilman and Dr. Louis Goodman. Now, they again noted that this decrease in blood cells, leukopenia, but interestingly, they found that lymphomas in experimental animals dramatically decreased in size when exposed to mustard gas.
Oh. And is this something they just tried it on, or it was kind of an incidental finding?
Well, they were looking to do more advanced versions of what mustard gas had been in trench warfare. Because remember, they're studying chemical warfare, but also how to treat chemical warfare against them, or chemical welfare.
Oh, okay, gotcha. So if you got a soldier who had been hit by mustard gas or something, like how to make them better.
But what brought the medical community's attention to the Yale group study, because that was really the very first documented study to show a benefit from chemotherapy in a human kind of cancer. So shrinking lymphomas by exposing them to mustard gas.
Oh, God.
But what really brought this to the great community's attention, because we didn't have Twitter, we didn't have TikTok back then. Instead, we had massive war accidents.
Okay. All right. So this got published in like newspapers.
Oh, no. Even better.
Okay.
The SS John Harvey, a Liberty ship stationed in Italy's Bari Harbor, the Italian town of Bari, had a stockpile of 100 tons of mustard gas.
100 tons?
100 tons of mustard gas. On December 2nd, 1943, it was shelled along with multiple other ships. The ship sank, the mustard gas rose, and the entire town was accidentally exposed as a result of the bombardment.
Wow. Okay.
In the days and weeks following this massive catastrophe, civilians as well as other military began to develop the signs of mustard gas exposure similar to what had been seen in Gilman and Goodman's studies. Colonel Stuart Alexander, an American physician trained in chemical warfare, confirmed exposure to mustard gas based on these symptoms and the autopsies of the soldiers who had died from the ship. And he brought in his report the attention that this chemical agent could be very useful in killing rapidly dividing cancer cells, especially ones based in the blood. As a consequence, people really began to look at the event at Bari with the knowledge that mustard gas on blood cells could have medical use.
Wow. Okay. So the alkylating agent, just like you said, mustard gas. So, Nicole, what are some of the descendants? I mean, we're not giving kids mustard gas anymore. Like, what are the modern alkylating agents?
So, some of your modern alkylating agents would be like cyclophosphamide, melphalan, busulfan. Those would be things that you kind of think about with that. And they are used very frequently, and they do cause secondary AMLs. So acute myeloid leukemias. So we do have to, it is something I have to tell people before I start chemotherapy. Very low percentages, but there is a risk that will cause another cancer based on our chemotherapies.
Oh, so you'll treat the original cancer, that one will go into remission, and then later in life, because of this DNA damage, there might be another cell line that gets affected, and it'll sit latent for a while, but then it'll start rapidly dividing somewhere down the road and become a new cancer.
About alkylating agents are about 5 to 7 years after exposure.
Gotcha.
when you get that secondary AML. So we do follow these yearly after they hit that 5-year mark. It varies how frequently we see the kids depending on the type of cancer they have post-treatment. But usually when you hit about 5 years, it's yearly. And then when we pass them on to the internists, when they age out of peds, most places in the country don't have adult oncology centers that have long-term follow-up for kids. There are definitely exceptions to that, but it's usually bigger cities. It's LA, it's New York, it's, those kinds of places. So the majority of the country doesn't have that kind of access. So we'll give them a summary of what treatment did they receive and what follow-up do they need because of that, since they're probably not going to be seen by an oncologist, so that, they can go to their primary care physician and they can run the screening that they need because of what they were exposed to as a child, such as get a CBC every year to make sure that you're not developing a secondary cancer, and check the heart because you had this kind of exposure every 5 years or every 2 years. Okay. So yeah, it is definitely something you have to tell people. I've never had anyone tell me don't treat the cancer because there might be a secondary cancer, because the rates are still quite low. I think it's 3 to 5%, if I remember correctly off the top of my head, but it is a real risk.
Much more benefit though. Okay, gotcha.
So you mentioned that really survival rates started improving in the 50s, and that was sort of between Dr. Sidney Farber discovering methotrexate and mustard gas from World War I turning into nitrogen mustard, a cancer treatment.
Okay. What a strange combination.
These were single agent treatments, which did improve survival time, but still were only achieving very minor things. However, in the late 1960s, and this is not necessarily a fact that you'd be unaware of, I just wanted to say it. In the late 1960s, you got the introduction of one of the first combination chemotherapy agents, nitrogen mustard, vincristine, methotrexate, prednisone, or as it's abbreviated, and I think it was 2 cycles, the MUMP protocol. MUMP.
Okay, so this is back when it was nitrogen mustard gas, before we had modern alkylating agents. Oh dear. Okay, gotcha. But now, so Nicole, this is what you were talking about. Now we've got boosted survival rates from combination.
In the 60s, in the cooperative groups. Yeah. Because really there's, I think it's like 1,600. I don't have all these stats in front of me. I'm sorry, but I think it's like 1,600 ALLs are diagnosed a year. So if, a decent sized adult oncology center that treats breast may have 2,000 breast cancers a year, we're getting, not very many ALLs per year nationally. So we have to work together. That's why the cooperative groups are so important, and why it has revolutionized pediatric oncology. And as we're moving into the era of immune therapy, our colleagues in internal medicine are having to kind of learn from us, because when you get down to that targeted exact mutation, all of a sudden your numbers go down and you have to work together to get good data.
So let's talk about that. You're really on the cutting edge of disease treatment, because you deal a lot with genetics, with immunotherapy, with things that those of us in the internal medicine side really don't think about outside of comic books.
No, the oncologists do.
They try to think about it the way that you do, but they fail. No.
So tell me about what's, in broad terms, what is immune therapy, or how many cancers need to be examined for a genetic component when you're dealing with children? Are cancers tend to be more inherited? Is it because during this growth phase you have more rapidly dividing cells in sites like bone and blood? What's the base level of knowledge that we're starting?
That's a loaded question, like why kids get cancer.
And not why they get cancer, but why certain cancers tend to be more common.
In kids, it probably is related to, what's rapidly dividing and, the growth and whatnot. I don't think I know exactly the answer to your question off the top of my head. But it definitely does trend in certain ages. Like the bone tumors tend to be more in adolescence, where we're seeing a lot of bone growth. So, I think you probably have hit something on that. The leukemias are oftentimes the mean age for an ALL is, I think, 3 to 5. So I think it probably does have to do with what's, growing at that time and how they're growing and changing. Neuroblastomas. or an embryonic tumor they're seen in babies and very small children, like toddlers, preschoolers. So yeah, I think it probably does have to do with that.
Okay, so kind of what the cells are at each phase, which is why there's such a wide variety. But no, we're not going to ask you to tackle why children get cancer.
Yeah.
This is the cheery episode.
Yeah.
Remember.
But the one thing I didn't hit on is that pediatric cancers, in variance with more of the traditional adult oncology, tend to be more homozygous, and that they have many of the same mutations. And so there's less differences amongst the group. And so we'll be able to see certain changes in these kids. And so a lot of times, as these new meds are coming out, we kind of know if it's likely that they're going to have a certain mutation or not, because they tend to not, or they do or they don't, and it's not as much variety.
And I think we're going to have to ask that before we close out. I'm going to have to ask you to tell this story about rat poison and zit cream, because I need to know. I won't be able to sleep tonight.
I spoke too soon. I can't remember all the historic how they came up with it. But basically, a subtype of AML, this promyelocytic leukemia, it causes you to have abnormalities of your coagulation proteins, and they can actually bleed to death. And you don't need to do traditional chemotherapy necessarily for them, but they respond very well to differentiating agents, which would be like your retinos. So they're used, it's not quite the same thing that you're using as zit cream, but it's retinos that are being used on these kids, and arsenic.
That's right.
Oh, my favorite Victorian medicine, and poison.
And we still use it. It's on it's on the boards. So, arsenic and retinoids.
Retinoic acid, which you use for this.
So it's, it's like on the boards. I think I distinctively remember for the pediatric boards, not the hematology, oncology boards, but the oncologist saying, "How could you beat our subspecialty? We use zit cream and rat poison." And it has a great survival rates. Now, some of them do, depending on how they present, and they do still get conventional chemotherapies, but we do use those agents, and they are able to take that cancer and move it from this early progenitor cell and push it along to where it differentiates or becomes that adult cell that should be there.
Ask your doctor if you qualify for the rat poison zit cream combination, but please don't use those phrases. That's amazing. And I think really we can't top that, although it does make me think as a Halloween recommendation film, go watch Arsenic and Old Lace. Delightful. Yeah. That's it for this week. Thank you so much for joining us and for your expertise, Dr. Bakke.
You mentioned Children's Oncology Group, but any of your favorites in terms of childhood oncology that are doing great things? So the National Institutes of Health, the Children's Oncology Group, anybody?
Probably the Children's Oncology Group would be the one that I think is making one of the biggest differences. It's funded by the NCI. It includes all of North America, or I shouldn't say all of North America. It includes the United States and Canada. It includes parts of New Zealand and Australia, as well as portions of Europe. And some of the European groups have also, collaborated with the Children's Oncology Group and done joint studies when, as I mentioned, some of these cancers are so rare. And if you want to get to statistical significance, you have to work in bigger groups of data, because you may only have, for example, neuroblastoma, 700 new cases in the United States total per year. That's it. So if you're going to get new data, and that, that's all comers. So it may be somebody who's a phase 1 or, stage 4 versus somebody who's a stage 1, and they're vastly different in how they're treated. So we have to work in these groups together. And there also is it's the arm that does kind of the fundraising outside of the government, and that would be the Cure Search. So the curesearch.org is a great organization. They provide resources to families, education. That's really a safe place to go to get information that it's going to be. It's written by pediatric oncologists. It's written by this research group. It's going to be validated. You're not going to get some scary old wives' tale of what you need to do. It's going to actually tell you, and it will also cite any other good resources and things that would be good education for someone that is having to face something like a child having cancer. Donating to the Leukemia and Lymphoma Society, they give grants of America. The Leukemia and Lymphoma Society of America gives grants to families to help pay for things like gas to get to the doctor's appointment. Those are all things that add up, especially if it's a 2-family household that's working and now you're down to 1 person or 1.5.
Sure.
So if you wanted to know who I would donate to, it would probably be those types of organizations. And then be the match. If you want to be a bone marrow donor, it's very easy to, put yourself in the registry. And if they find someone, you don't necessarily have to do it, but you could potentially save someone's life.
Yeah.
And it definitely is a Caucasian Eurocentric kind of pool in general. I think that there's more of them in there. So any kind of group that is underrepresented. And if they don't have a match within their family, they may not have a match.
Sure.
So, luckily we're able to use like half matches now. So there are more options, but that's another thing. Like if you don't have money, but you'd be willing to give part of yourself.
Yeah. And
to help a stranger.
You're not using it. I'm telling you right now. You don't need it.
You'll
you got
regenerate
plenty left over. You'll regenerate it. So stop being so selfish there, you listener, you.
Wolverine would do it.
Well, I always think if the toddlers and preschoolers can donate for their siblings, can't be that bad.
Absolutely. Yeah.
So that's it for this week. As always, we love to hear your comments, questions, and feedback. This show is produced by me with a lot of help from Dr. Santhosh and friends. Our theme music is composed by Rachel Leisure. If you would like to hear this show ad-free or with some additional bonus content, try out our subscription tier. Why not? And until next time, as always, wash your hands, get your shot, wear a mask, find a country that has something you want to see. And when you've done all of those things, happy travels.
Bye, guys.